And I am honored to be invited on this platform to be able to share my thoughts. So I'm going to share my screen, and the way I normally take a session like this would be I want it more to be interactive session as opposed to me just giving a half an hour to an hour lecture. I want you guys to indulge in the talk. I want you to, interrupt me at any point in time to ask me questions. So I was invited on this platform to, give a talk on mastering research fundamentals, finding mentors, generating research ideas, and achieving quality publications. So in essence, we are just going to be talking about research, and it's all going to be about research. And the way I think I would be able to explain to you guys at your level is, how to take a start with research. How did I do it? And maybe I might be able to inspire a few of you to take the same path as well. So just before I take a start, can I ask what is the general level of the participants in the group? Do we have students? Do we have trainees? Do we have aspiring pre-medical students in the group?
It's actually a mix of all of them. So
Excellent.
we have
Amazing.
students
Amazing.
from first year
Right.
to like
So
first year and all.
that is really good. So I'm going to cover all bases, and I will, I've tried to make this talk as simple as possible in the sense that, I make it more palatable. I don't want to make it more theoretical based, right? Because you can find all sorts of theories. I did my master's. It took me 2 years to do it. So there's no end to it, right? People go on to pursue PhD. So there's no end to, but I wanted to make it more palatable. I wanted to make it more enjoyable. So I leave the last 10 minutes for discussion, and I'll, open the house for questions. But I do want you to stop me at any point. At any point, if you have any question, just, unmute yourself and ask me anything, right? But I'll still leave the last 10 minutes so that we can have, some more interesting discussion. So I have no conflicts to disclose. And the goal is, what do you take away from this? So from this next 40 minutes, you'll take away the basics of research fundamentals. How do you generate ideas? How to, find mentorship in research, and how do you perform quality research? Now, we talk about let's talk about mastering research fundamentals first. So the big question that comes to our mind, in essence, is why do we publish, right? Why do we get into the whole mess of research? Because you would find clinicians, you find surgeons, some of them who are highly published, who are academics, and on the other hand, you'd find people with hardly two case reports. Now, the question is, why is the first question, right? Why do you want to be publishing? So in my mind, the first thing that comes to my mind is, we've got a moral obligation. Just like physicians, we learned it from someone, and we should teach it in return. I think with research as well, it's our moral obligation, to be able to, learn from our patients, which we do. We learn, we grow every single day, and to be able to pick up something that could be life altering, treatment altering research. And then, we should never discount personal gains, right? When I was a medical student and when I was a trainee, every time you talk to somebody, they would talk to you about morals and ethics, and they nobody talks to you about personal gains, right? So to a certain degree, if you ever hear the most successful people in the world talk, you hear anybody talk, right? You look at Elon Musk, look at the guy who, look at everybody. To a certain degree, you've got to be selfish, right? You have to be, because this is for your self gain as well. So I will tell you upfront, I'm not going to sugarcoat it. Research also gives you personal gains, right? And how does it do that? It gives you acknowledgement. It allows you to collaborate, and it leads to promotions as well. I don't know of one surgeon at AKU who's been promoted without having publication. So it does lead to promotions. I mean there is self-interest that's vested in it, other than just moral obligation and ethics, which is a very arbitrary and loose term that's used all around. I'll give you a very recent example. So Bill Gates was at AKU, right? Um, quick question. Would he had been in AKU if there was no research at AKU? Why does he care, right? Why would Bill and Melinda Gates care to come to AKU unless it's for life-altering research, which is actually happening at AKU, which makes me proud to call AKU my alma mater. So I'll give you an example of this publication that came out in 2015 and 2016. And I'm an ENT surgeon. I'm an otolaryngologist, so I'll give you an ENT example. So I'll give you, I'll break it down to you very simply. So if you have oral cancer, for example, if you've got tongue cancer, you take the tongue cancer out, but we also know that tongue cancer spreads to the neck nodes, the lymph nodes in the neck. Okay. But what if I say to you, somebody has got tongue cancer and you do a CT scan of the neck and you don't find any pathological lymph nodes? Then the big question is, and this question has always been with the head and neck surgeons, is do you perform neck dissection or not? Now, neck dissection means taking out all the lymph nodes of the neck. Now, it goes without saying, neck is a region that connects the brain to the rest of the body. So it's high risk. You've got great vessels, you've got the carotids, you've got the jugular, you've got the spinal accessory nerve. I mean, you've got boatloads of stuff within the neck, right? So it's high risk procedure, right? So in experienced hands, it could be 40 minutes, but in inexperienced hands, I've seen neck dissection taking 6 hours long, right? So, and it's not an easy procedure. So the big question is, if there are no neck nodes, pathological neck nodes that are picked up at the time of treatment, at the time of surgery, should somebody perform neck dissection or not? So this paper comes out of India. So Anil D. Cruz over here was the lead author on this. This was a randomized controlled trial on 10,000 patients, randomized controlled trial on 10,000 patients with head and neck cancer, with oral cavity cancer. Can you imagine? This was a big study. And what it showed was patients who had elective neck dissection, which means even though there was no neck node on a scan, had undergone neck dissection as compared to therapeutic neck dissection, which means you did the oral cavity resection, you sent the patient home, you kept him on follow-up, and when the node popped up, you performed a neck dissection. When they compared these two groups, the patients with elective neck dissection had better prognosis. Now, when this paper got published, and this is published in NEJM, which is like what, 60 impact factor, when this paper got published, this was such a big paper back in, and I was a trainee at Khan at that time, and I remember that this was such a treatment guidelines altering paper that it sent waves across the world. This paper comes out of India, and this paper changed the guidelines all over the world, right? So when I say India, I also mean India, Pakistan, Bangladesh, all of these SAARC regions. They're predominantly the same. We're divided by geography, but pathology is the same in the whole of this region, the subcontinent. So it's such a treatment guidelines altering publication comes out from this region. So, we talked about moral obligations. There you go, right? I mean, it changes the treatment. It has practically changed the paradigm. Now, very briefly, I'm going to touch upon the basics of research. We know there are different levels of evidence. Systematic reviews and meta-analysis along with randomized controlled trials is level 1 evidence. That's the top of the pyramid. Cohort and case control studies is considered to be level 2 and level 3 evidence. And then we have got case series and case reports as level 4 and 5. Sorry, that was cohort and case control. So the meaning of level of evidence is that if somebody has done a systematic review, let's say, for example, it is considered level 1 evidence, means you can base guidelines off it. Case reports is considered level 5 evidence because you can't really base guidelines out of case reports. So a case report is 1 in a million event sort of a thing, right? Something so rare, you can't base guidelines off it. But that should not, in your mind, and does not discount the fact that case reports are equally as important, because unless people publish case reports, if something which is that rare pops up anywhere else in the world, how would anybody know how to treat it, or what is the prognosis of it? Very briefly, I'm just going to mention this, that people are now recently publishing case reports and systematic reviews of case reports. So for example, if you got a case and there are just like 40 cases in the world, let's say, for example, and I recently collaborated on one with the trainee in Liaquat National, and we presented a case report, and then we did a systematic review of case report, and the case report that we reported was the 41st case in the world. So we included all the previous 40 cases, and that gives a comprehensive outlook on that disease and entity. There was thyroid hemangiosarcoma. So, and it's in the process of being published at this point in time. So what it does is once it's published, if this pops up anywhere else in the world and a clinician like me or anybody else wants to know what this disease is, and how do we counsel the patients, they would be able to tap into the systematic review and would have a comprehensive understanding of how this rare disease behaves. So just so that you have this at the back of your mind and should not discount case reports. Now, briefly talking about how the studies work, we have got cross-section study. So we have got past, present, and future. If we are in the present, cross-section study can go in the past. So you can go 10 years back and you can review a group of cases, and then you can go ahead in the future and you can do a cross-section study as well. Prospective cohort study goes from the present to the future. So for example, you've got somebody who starts smoking and a group of people who don't smoke, and then you go forward in time and you want to look at who developed lung cancer or not. Similarly, you could do a retrospective cohort study. So you could have a present group and you can go back in time and look at their exposure. And similarly, you've got the case control study in which you already have the outcome, but you want to look at the exposure. You want to go back in time. Randomized controlled trials, which is level 1 evidence, is always goes from the present to the future, goes from the exposure to the outcome, from the intervention to the outcome, always. So just so that it gives you an understanding on how the studies work and which direction do they go into. Now, here's the big question, right? How to do it, right? Because everybody wants to know how to do it. So I published my first paper, and it was a case report, and I'll talk to you about it when I was a second year trainee at AHA. Now, I must say this to you, that all of the people who are attending this workshop, hats off to you because you're taking an early start. Now, if somebody takes an early start, and I always wish and I always think, I wish that if I had this insight when I was a medical student, I would have walked away with 70 publications. And I know medical students at AKU who have had 50 to 70 publications. Now, imagine you are going for a match in the US, and imagine you're given your PLAB and you want a specialist training post in the UK, where I am at the moment. You walk in with like what, 50 publications, let's say, for example, or 40 publications or 10 publications, and somebody just walks in with saying, hey, I got the PLAB in my hand, right? So if I was to choose, or for example, if you were to choose, who would you pick, right? And this is a big question. How do you do it? So I always say, the first and the most important aspect is the research question. You've got to have a good research question. If you have a good research question, it leads to a good paper. Similarly, bad research question leads to a bad paper and a bad outcome, and it becomes miserable because no journal wants to accept it. It gets rejected and gets bounced here and there. When I was doing masters from AKU, one of my mentors over there used to use this phrase over here, and I absolutely love it. He used to say garbage in, garbage out, right? If you put in bad data, the software that you're using is just going to perform the analysis, right? The software does not know what you've added. So if you've put in bad data in it, and it's not making sense, it's just going to run the numbers. It does not know what data you've put in. So if you put in bad data, you will have bad outcomes. You'll have, bad results. So again, it just highlights the fact that you've got to be very cognizant of what the data is being collected on, who's collecting the data, and making sure that there's no problems in data collection. Now, we are talking about a research question. And again, as an ENT surgeon, as a rhinologist now, as an endoscopic sinus surgeon, so when you're performing endoscopic sinus surgery, and you've got the endoscopes, and now even the neurosurgeons, there's just like spine, both neurosurgeons do it and orthopedic surgeons do it, rhinoplasty, ENT surgeons do it, and plastic surgeons do it. Similarly, endoscopic sinus surgery or endoscopic skull-based surgery, you've got ENT surgeons and physicians who do it, and then you've got fellowships like I did in ENT, and then you've got fellowships in neurosurgery who do it. So one of the most important aspect of endoscopic skull-based surgery is bleeding. So you've got nose, which is a very small cavity. You've got the roof of the ethmoid, the sphenoid. It's a very small area. It's practically a few centimeters. And the biggest challenge during skull-based surgery is bleeding. right? So if you have bleeding during sinus surgery or skull-based surgery, that's an endpoint. Why? Because you've got an endoscope in your hand. An endoscope has a very small lens, and if it gets painted every now and then again with blood, you can't see anything. So in order to have good outcomes, you've got to reduce the bleeding. You've got to practically have cadaveric fields, right? So the question basically that came to my mind, and this was the COVID era, the question that came to my mind was, how do you reduce bleeding during sinus surgery? So one of the elements that was described was the head up position, or the reverse Trendelenburg position. So if you have the head up, there's more venous pooling in the legs, there's less of the venous return, and there's less bleeding during sinus surgery. But the question then was, what is the optimum degree of head elevation? Is it 5 degrees? Is it 10 degrees? Is it 15 degrees? I mean, do you sit the patient up? I mean, what is it? Is it 3 degrees? So it just can't be arbitrary. You can't just walk into a theater and say, yaar, uska sar upar kar de. That's pretty, and as scientists and as physicians, as, thinking surgeons, we want to know the exact numbers. So, I performed a systematic review, and we came out just with 3 randomized controlled trials. We performed a systematic review, and it concluded that overall there's a reduction in mean blood loss, bleeding per minute, but there's no consensus in literature on what is the optimum degree of head elevation. Is 15 better than 5? Is 5 better than 10? Or is 15 better than 5? So nobody knows is the answer. And we were then able to publish this in American Journal of Rhinology and Allergy. It was 1.9 at that time. It's over 2 impact factor now. So it just goes on to say that even though the systematic review had 3 papers, but the research question was such that the editor-in-chief and the editors and the reviewers were like, well, I think this deserves publication. This deserves to be highlighted. So if you don't have a good research question, I'm telling you through my personal experience, I've had misery in publishing those papers. So think about research question. Now, before starting off, whether it's a systematic review or any original study, other than case reports, I always recommend that you should always have a study protocol. A study protocol helps because it helps the whole team who's working on the research project to be focused. They would know what the outcomes are that they're looking at and what the data is to be collected. Now, the other benefit that I also find in writing a study protocol is that almost half of the manuscript is almost ready. What that means is, जब आप protocol लिखते हैं, the introduction and material methods part is already written, right? And I'll talk to you about how to write introduction, how to write material methods, but practically that bit is already written. Once you start collecting the data, it's only the results and discussion that comes afterwards. Introduction तो आपने पहले लिख दिया है, और आपने material methods भी लिख दी हैं, how you're going to do it. So by the time you're done collecting with your data and the data analysis is done, half of the paper is already written. So I find it very useful if half of the manuscript is already written. There's always a question whether you should publish the protocol or not. For systematic reviews, it holds more true. One of the advantages of publishing your protocol, there are certain journals, certain areas that do publish protocol, that it adds to the list of publications. So you have published a protocol that counts as one paper, then you have published a paper that counts as a second publication. And it also helps with publishing the original research. So if you go on and if you add one line saying that we did publish the protocol, it just adds more value. But this isn't something that I would fuss about. So for example, I wouldn't necessarily say in all cases, do publish the protocol. But if it's a large study, if it's a research question that you're aiming to publish in a high impact factor journal, I would err on the side of publishing a protocol. I think it helps. Ethical review committee. Before the start of every study, you should have an ethical review committee. You should have your protocol run through the ethical review committee board. If you're working in AKU, this is mandatory. You've got to have it done. AKU is lucky enough to have an ethical review committee board. Most places don't. It's also called an institutional review board. Again, this helps because if you are to run anything through the ethical review committee board, you would have written the protocol anyways. Its approval ensures that the study is being following their declaration of Helsinki. We'll talk about it. And then there's some journals, the most noticeable in Pakistan are the JPMA and the JCPSP, both indexed journals. both of them do require an ERC number. So that's one thing that you have to work on. And Declaration of Helsinki is autonomy, beneficence, non-maleficence, and justice, which means autonomy is patient has a right to refuse or choose his treatment. So you are collecting the data from the patients, but these patients have to be consented, whether it's a generic consent as a part of treatment at AKU, let's say, for example, but the patients have to be consented. Especially if you're running a randomized controlled trial, you're giving patient A some medication, you're giving patient B placebo. Both of them have to be consented because they don't know what they're receiving and they could have an adverse effect, and they can decide not to be a part of this trial. Beneficence is practitioners should always act in the best interest of the patient. If for example, if you know that the patient has penicillin allergy और आप कह रहे हैं कि जी ट्रायल करने जा रहे हैं और आप उसको जो है ना ऑगमेंटिन देने लगे तो you know he's going to be allergic. So you've got to be very careful while you do that, because then you've got to make sure that you don't either enroll the patients or they're not. I mean, you can't say in a randomized controlled trial that they can't be in that group, but then you don't enroll them. Non-malfeasance is do no harm, more good than harm. You can't say to someone, I mean, you can't compare penicillin to placebo, and then the third arm is something that gives harm, right? You can't poison someone, right, to show beneficence of penicillin, right? So do no harm. And justice is distribution of resources. Now, you shouldn't ideally, I mean, dedicate all the resources एक trial के ऊपर, and then you've got more studies and so on and so forth. This is just a general understanding. Data collection, we talked about it. There should be a preformed questionnaire. It just can't be random. You just can't cook up questions at that time. So it has to be a preformed questionnaire. Ensure data entry is not falsified or does not have a typo. So for example, this has happened. This is a practical thing that I'm talking to you about. We have had cases where by mistake, of course, by mistake, there was a typo, right? And we were able to pick it up. And it was 19 instead of 91. And so this is something that you should be able to pick up, and you should be able to see that this does not happen. There are ways to pick it up. कि अगर इस तरह से हो जाता है, what do? You can randomly pick up 10% of the data and you can review the data. That's one way to do it. You've got to have then trained data collectors, whether they're medical students, whether whoever it is, they've got to have a formal training. It could be a half an hour, 15-minute, 1 hour session, but they've got to understand what is the data they're collecting, what is the importance of it, and just to make sure. Again, you've got to have a consent always for a prospective study whilst you're doing it. Data analysis, I would say, everybody should be versed to do data analysis. It's not difficult at all, trust me. It's not difficult once you know how to use it. These softwares such as Stata and SPSS are just like calculators. If you understand how to do it, you can do it yourself. Or if you can't do it, I would recommend having the statistics done by some statistician. It really helps as well. It saves time, but the only then challenge is you've got to explain to them what exactly that they're looking at. Again, a statistician is just like a computer, right? I mean, if you don't tell him exactly what you're looking at and what was the aim of the study, he's going to cook up data that wouldn't make any sense. Again, comes through my experience. It's had been the case. So. Again, descriptive analysis is very easy. You talk about means and standard deviations, median or interquartile range, and then basic statistics. It's very easy. T-test and chi-square test. I mean, you all can do it. I have certain medical students working with me at AKU who do regression analysis as well. So it's something that can be learned. You don't really need to do masters for it. Now, before I go on to how to write a paper, I'd like to, just take a pause and see if any of you have any questions, anything you'd like me to elaborate more on or speak more on. And I'm happy to take questions, trust me. This is not this is not a session. This is not, I mean, if you're not going to ask me questions, just saying, you might as well watch a YouTube video, right? So I'm going to keep on going, but if you do want to stop me, please just unmute yourself and ask me questions. Again, now the big question, because I put myself, when I was making this presentation, I was thinking about myself and my time when I was writing my first paper and, the challenges I had. The next question is, how do you write a paper? And what are basically the elements? So when I was very new at this whole game, I still remember, I used to go around and I used to be asking people, Bhai, just tell me how to do it. I will do it. You just tell me how to do it. And for whatever reasons, I won't delve into that, but I never got a good answer, right? I mean, and once I learned how to do it, and I thought to myself, man, this wasn't difficult. I mean, I just wish, people made it easy. So I'm just going to break it down for you. I'm going to make it easy for you guys, right? So how do you write an introduction, right? Introduction, like you introduce yourself, and like Dr. Mariam introduced me. It's how you introduce your audience to your papers. Introduction predominantly has three paragraphs. The first paragraph is what is known, the second paragraph is what is unknown, and the third is the most easiest, which is the rationale and objectives. Now, what do you mean by what is known? So let's talk about, again, I'm a sinus surgeon, I'm a skull-based surgeon, so I'm going to tell you, let's talk about, sinus surgery, So the first paragraph is going to be, what do you know about sinus surgery? Or for example, if you want to talk about neurosurgery or glioblastoma, let's say, for example. So you say, what is known about glioblastoma? What is the incidence? What is the prevalence? What is the cost annually that incurs on patients who have this? What is the prognosis? So very briefly, the introduction is usually 400 to 500 words. Anywhere in between that is considered a good introduction. So the first paragraph is going to be talking about, let's say, glioblastoma, right? The second paragraph is going to be what is unknown. What don't we know about it? Is, for example, if you use surgery, open surgery versus endoscopic surgery. I'm just making this up. Or for example, you use cyber knife versus open surgery versus conventional radiotherapy. What is the outcome? So what exactly are you trying to look for? What is unknown? What still has sort of discrepancy in the literature? So when you cover what is unknown, the third paragraph becomes easy, which is rational and objectives. You say, oh, because of this, because we don't have enough evidence on this, and this, for example, not convincing evidence in the literature, we aim to do this. So the objective starts with the phrase, the aim of this study was to, look into XYZ. An objective could be just one, or it could be more than one objectives. I normally say that primary objective should be written in the introduction. The secondary objective can go down into the material method section. Now, this is the question I used to hear a lot. Study not conducted in our region could also be a rationale. Now, what happens is, most of the time, what happens is you come up with the research question and there's already work done on it. So some of the people you go and talk to would be like, why do you want to do it? There's enough evidence out there. I still believe that if Pakistan ke andar, the thing is, anything that you pick up, Pakistan ke andar jo hai na, it's never done, right? So you're the first one to do it anyways, right? In my mind, if you have a well-constructed question, right? And your argument is, well, we're doing this study because it's not conducted in our region. In my mind, that is still a valid question. That is still a valid reason to do it. The only difference then is that you would then have to aim for local journals, because why would Iran want to know about any demographics about Pakistan? Why would an Iranian journal publish it? Why would the American journal publish it? Unless you have a paper like Anil T. Cruz's paper, which is a big randomized controlled trial, then everybody cares, right? Everybody listens. So just this is just to give you that brainstorm. Let's talk about material methods. What are the elements that you cover in material methods? The first line should always be that you have had an ERC committee approval. In brackets, it's nice to give the ERC number or IRB number. Then you talk about study design. Was it a prospective study? Was it a retrospective study? Was it a cohort study or case control study? Then you talk about study duration. The study started from January 24 to July 24. Let's say, for example, study setting. Was it a DGH? Was it a tertiary hospital? What was the area what was the region where the study was conducted? What is the sample size of the study that you collected, and what was the sampling technique? Was it randomized? Was it consecutive patients that you've picked up? So this allows then the reason I've given you these headings is, once you know these headings, it's then easier to fill in the blanks, right? It's easier to write the material methods once you have these headings with you. And then you further go on, you talk about eligibility criteria. Eligibility criteria, you talk about inclusion criteria, you include an exclusion criteria. Usually the eligibility criteria should be like a funnel, like over here. So you start with a broad inclusion criteria. We included all adult patients with, let's say, glioblastoma treated at the Aachen University. This is a very broad inclusion. So it's a broad umbrella. And then exclusion criteria is you start picking out everything. You say, okay, so patients who have had private therapy were removed, patients who had missing data were excluded, patients who did not consent were excluded, and so on and so forth. So it's got to be like a funnel. Then you do mention what statistical tools you've used, whether you've used SPSS, whether you've used Stata, or whatever you're using. Again, if the tool is used, talk about its details, the company with the version of it, and then do mention about the consent and assent from the patient. Assent is from children below 18 or 16, and consent is from adults. Do mention about the consent. A single line saying that prior consent was taken before the start of the study is usually adds more value to the paper. I also say that write it in paragraph forms, also give subheadings if you can. So if you give these subheadings, the ones that I've mentioned, it just makes it more palatable for the reader, and makes it more convenient for people to pick up stuff from the paper. When we come to the results, the results have got to be shortened to the point. So results have two components to it. You've got descriptive data, and then you've got the table format. The descriptive data has got to be shortened to the point. So you would say 195 patients were included in the study. The mean age was this. The mean gender, the gender was this. The frequency and proportion of gender was this. And just write the most pertinent results in words. Why? Because then you will have to make the tables anyways. When you start making the tables, the first table is always the demographics, right? You talk about the patient's age, you talk about the patient gender, you talk about comorbidities, you talk about the inclusion criteria. For example, what was the reason why they were included? So the first paragraph is always generic. It's always about demographics. The first paragraph, it allows for the reader to whiz through and understand the population that was included in your study. And second table and so on and so forth then talks about your analysis. It could be univariate analysis, it could be multivariate analysis, it could be means and standard deviations and p-values. These are going to be second tables and so on and so forth. And then you can add graphs to make your paper look much better and your results more palatable. Talking about discussion, the discussion usually has 4 paragraphs. You almost always start in one line, give the summary of your results. So you could go on to say that you have a 195 patients with glioblastoma were included. The prognosis was this. The 10-year or 5-year outcome was this. Full stop. Then discussion is all about, like we discuss, it's like चाय पे जो गपशप लग रही होती है, चाय पे समझे गपशप लग रही है discussion session के अंदर. You're like, you pick up paper, you say, oh, well, our study findings was this, that study was conducted, they found this, or you could say our study findings concur with those studies. And you should ideally quote the most recent studies, right? So if you say, okay, our study findings, are similar to that published in Brazil in 1991. I mean, who cares 1991 what was happening in Brazil? People would rather want to know what's happening in India in 2023 as opposed to, US in 1991. So again, JPMA is very fussy about it. They don't like to see references before 10 years. I think that's a bit dodgy in their part. I don't know what they're trying to aim for that, but most of your references should ideally be the more recent references. Of course, if there was a definition that was laid down in 1960, you've got to reference that. So you can't really change that. So that's just to give you an idea. And if you don't have results that are comparable or compatible with your results, then you hypothesize in discussion, why could that be? Well, could that be the demographics? Was that because the patients there don't have access to PAN and Chalio, which is the case actually? There's so much oral cancer in Pakistan and India. It's just because of PAN and Chalio, which is not so much present in the West. And then the last paragraph is the last two paragraphs is the second last paragraph. You talk about limitations. You talk about, okay, what were our limitations? You could talk about, we collected data in 6 months. We could have done 1 year. We had some missing data. You have to talk about limitations, like it's have to. And then the last paragraph of the discussion is implications and future prospects. So you've conducted the study, but what do you aim out of it, right? You found this. The implication could be that this could lead to further larger randomized controlled trials, let's say, for example, or multi-center studies. And then future prospects are, it could change guidelines and so on and so forth. So this again has to be catered according to your study. Ideally, it should be catered to your results. And the conclusion should be precise, and it should conclude the findings of the current study. What I mean by that is, in conclusion, if I say, oh, glioblastoma is a disease with poor prognosis, well, that does not mean anything, right? I mean, it practically does not mean anything. It has to be more specific. You would say, okay, the 5-year survival of patients with glioblastoma multiforme was, let's say, 37%, right? This is more specific to your findings. So conclusion, the biggest mistake people make, and I've done that as well, is putting in generic things in conclusion just to make it look fun, just to make it look more interesting, which should not be the case. Then the final thing comes is abstract and referencing. I usually use EndNote for referencing, and I tend to write the abstract at the very end of the paper. I find it easier because once you've completed the paper, writing an abstract is very easy, right? You just got to pick up a few lines from every section, and you make an abstract. And I also find it difficult to make an abstract if you don't have the results. If you don't have the results, how can you do the conclusion? So I prefer to write the abstract at the end. Some people say they do it at the start. I just find it very difficult. I don't know how they do it. So hats off to them. That is how you write a paper. Now, this again is very interesting bit. How do you find mentors? Again, guys, if you want me to stop at any point, feel free to stop me. This is not a session. This is not a lecture. And this is, just ask me any questions. Yeah. This again, finding mentors. For me, I think this is probably the most important thing. I think if I was to say what is the one most important thing, I would say it's finding mentors. If you have the right mentors, I think this takes precedence over the research question. If you have the right mentor, then the research question becomes easier as well. If you don't have a right mentor, then you're actually firing in the blind. You don't know what's happening. So I think it's more important over here. I remember speaking to someone about finding mentors. I was talking to Prof. Amin Jawar from Vancouver when he was in Karachi a couple of years ago, and he said something interesting, and I concur. He's like, if you look at the best players in the world, the best players, let's talk about the best players in basketball, because basketball is what I used to play, and I hope I still play in the future as well. So is the more one of the best players in the basketball is Michael Jordan, right? And he is the GOAT. So the question is, was Michael Jordan's coach also Michael Jordan? The answer is no. So the point that I'm trying to make is the coach or the mentor does not necessarily have to be better than the player. Right? Now, you might find it counterintuitive. You'll be like, hey, bro, what are you talking about? I need somebody who I can look up to. You're saying to me, he does not have to be necessarily as good as you. But hold on, let me try to elaborate what I said. What I mean by that is, you want someone to help point you in the right direction. They might not have 300 papers, but they would have enough time for you to guide you in the right direction. If somebody already has 1,500 papers, and there is a neurosurgeon in the US who's had 1,500 papers, and that was like a couple of years ago when I was going through ResearchGate, he doesn't have time for you, right? I mean, I can tell you, he doesn't have time for each one of you to take you through. So you've got to find the right mentor, the person who has got the right skill set and who can give you time is what I mean by this. So how did I do it? This, I think, was the most difficult task. Again, when I was a trainee, I wanted to get into research. I wanted to get into publication, and I was miserable because I couldn't find a right mentor. I think just to have the right mentor, you have to start speaking, right? Go to people, speak to people. AKU more recently has taken this initiative. They started when I was again a trainee back there. These interest groups, right? So I think this is a great initiative. Why? Because then you can have like-minded people in one group and all geared and all focused towards one task. So I think, hats off to all the interest groups, because I think that has really helped uh, get people who want to do the same. So I would say that in order to find the right mentor, speak to people, right? Now, who to speak to? There's some people who would discourage you. They'd be like, oh yeah, publish karne se kya hota hai, and stuff like that. But speak to people who are already working on a project. So if you speak to someone like Dr. Saad, if you speak to someone like Dr. Atharinam, they're already working on projects. So what they can do is they can help you, patch you up with the right people. Okay? And find the right mentor. There are a lot of naysayers out there. There are a lot of people. If you go to someone jiske paas 2 case reports hain, of course he's going to discourage you, right? But if you talk to someone like a Neil D. Cruz, who's got like a groundbreaking randomized controlled trial that's published in any JAM, or you go to, let's say, people like pediatric department, Faiza Jahan and stuff, they would encourage you. You go to Dr. Saad, he would encourage you. So you've got to find the right mentor. Just don't listen to anybody. Find the person who you think clicks and would have enough time for you as well. So that's important. Again, this, I can't highlight this enough. When you're talking to people, these are busy clinicians. Bear this in mind. They're physicians, they're surgeons, they're busy, they've got patients, they've got families, they've got their own projects, they've got a million things happening. It is your project and you have to put in the effort. Nobody can write it for you. You have to take the initiative. You have to put in the effort. You have to keep on following them and chasing them. I have a group of medical students who are working with me on systematic reviews in AKU. They are some hungry students. I hope they find me as a good mentor, but I'm blessed to have them likewise, because if I forget, for example, let's say, for example, and I just got one message right now, is they keep on reminding me. So for example, if I've got half a day today, I would just whiz through, and I would be able to go through the project. So you have to keep on following and chasing your mentors, and you've got to have those mentors who do then have time for you as well. So it's a two-way street. So I was talking about my first case report. So my first case report, 015, was when I was an R2 at AKU, and this was the paper that I published. It was hibernoma larynx with large multinodular goiter, unusual airway challenge, published in BMJ. I was lucky that my first case report got published in BMJ. So this was unusual because this was a funny story, because you've got a patient who's got a large thyroid gland, and he was consented for thyroidectomy. And at the time of intubation, there was this funny looking mass right above the glottis. Now, this became a challenge, because if you have got something which is occluding the upper airway, and the anesthetist cannot put in the tube, this is the epiglottis, and the anesthetist cannot put in a tube, can't see the vocal cords and the glottic opening, and at the front of the neck, you have this mega thyroid. This is like, what is this? I mean, this is like, two mangoes connected or whatever. It's summers in Pakistan. So if you've got this big thyroid isthmus, how do you perform tracheostomy? Now, for example, you've given a patient propofol, patient loses all muscle activity. You can't intubate from the top. You can't do a tracheostomy. This is basically a life or death situation. In this particular case, we were lucky to have a brilliant anesthetist with us. He was able to pass a bougie and railroad the ETT tube over this, and this was. I mean, this sort of became a life or death situation at that point in time. I was lucky enough to have Dr. Moghira as my mentor for this case report. But here's the let me just quickly. Okay, so I've got a question in the group. I just saw this, and the question was, how can non-AQ students connect with Dr. Athar or Dr. Saad and seek mentorship? I would say, so Faraz asked this question, I would say, speak to Dr. Simal or speak to Dr. Mariam, because they're leading this surgery in this group. and they would be able to put you through to them. So sorry, that's a bit of a task for you both. So sorry for that. Um, and then so moving on. So this one, but here's the funny bit. The next slide is the most interesting for me. And does anybody know who this is? So this is Dr. Vajad, right? And I'm an ENT surgeon. I'm an R2 in ENT, writing a case report on something that is related to thyroid, and it is miles away from the pelvis. It's in the neck, and Dr. Wajahat, and I gave him all due credit, and he was actually my first mentor at AKU. Now, can you imagine this? So Dr. Wajahat is a urologist at AKU, and I still remember I was on call. He was the chief resident in urology. I still remember I was on call. I was a year two trainee, and I was sitting in one of those rooms, वो B2 और उसके साथ C2 के साथ B1 या C1 के साथ, those doctor rooms, and I was sitting there, and I was sitting miserably. So I had actually written the case report, but I actually didn't know again how to publish it, how to go about it. And Dr. Vajat, as he is, superhuman being, smile on his face, super super helpful. He's got a lot of time for everyone. I mean, he walks in and he's like, and I still remember him saying, "Kya ho gaya?" It's like, the sort of that reaction, "Ki bhai, what?" And it's like, Dr. Vajad, being a year two, and it's like, "Dr. Vajad, sir, ye ho gaya." And, I've got this case report, and he goes on to me and he's like, "Why didn't you publish it in BMJ?" And first of all, and I thought he was joking. I genuinely thought he was, joking. It's like, he's sort of pulling my leg, and he's like, okay, BMJ. I was like, BMJ. He's like, yeah, yeah, yeah. He took me to his computer. He downloaded the BMJ template. He said, fill it up. I had 100 questions. He answered all of them. Fast forward a few weeks, and the paper gets published in BMJ, right? And I still remember going up to him, and till this date, I look back and I think that how significant of a role he played. The half an hour he gave me is the man I am today in terms of research, because that was my first paper. I would have been stumbling on publishing a case report for months on end had I not have Dr. Vajat to guide me. When the stars align और वो आपका दिन होता है, it was that day, and I still, so finding the mentor, it does not necessarily have to be your specialty. It just has got to be the right person who's got enough time for you to guide you and put you on that path. अब Dr. Vajat अपना है, मैं अपना हूँ, we are miles apart, continents apart, but I look back and I think how significant of a role he's had in my research and journey. Then comes the next question. Once you found the mentor, again, this is something that challenged me a lot in my days as well, finding the research ideas. Every idea that came to my mind was published, right? It was already out there. And I was thinking to myself, everything I think and I want to do research on is already published. Then where do I find research ideas? Now, in general, हमारे culture में ना हमें एक ही चीज सिखाई हुई है। हमें जब से पैदा हुए हैं, सिंस वी हैव बीन बोर्न, कल्चरली ना हमें कहते हैं कि बड़ों से सवाल नहीं करना, सवाल नहीं पूछते, जो है ना, और जो कहते हैं बस वो करते हैं, राइट? आई मीन, आई डोंट नो वन ब्राउन person who has not been through this generational trauma where we have been told not to think, कि बड़ों ने कह दिया बस करते हैं और बस पूछते नहीं है। And I think this is just culture. I mean, since I moved to the UK, I think this is a generational curse. अब एक तरह से ये बात अच्छी भी है और एक तरह से ये बात बुरी भी है. It's like a double-edged sword, right? I mean, I've got an 8-year-old son. उसको मैं पिछले दिनों कह रहा था कि बस पूछते नहीं है, ये जब बड़े करता है. I was thinking to myself, I was like, this is generational trauma that I'm passing on. This is not fair. So, this is. I'll let you hear what I'm going to show you now. So ये जो है ना, don't think just do वाली जो बात है, ये आप लोगों ने ना मैवरिक में भी सुना होगा. अब वो जब ये मूवी है, this is Top Gun Maverick, and this don't think just do वाली जो बात है ना, ये मूवी का स्टेटमेंट नहीं है. This is not the ये मूवी में जो कहते हैं. So Tom Cruise is saying to him, don't think just do. They're going on this big crazy mission to find this uranium, whatever. And he's like, just don't think, just do. So ये वो वाला don't think, just do नहीं है. हमारा जो है ना, हमारा generational curse जो है ना, वो different है. हमारा तो कहते हैं सोचो ही ना, बिल्कुल from the outset, don't just think, ठीक है ना. ये जो कह रहे हैं ना, don't think, just do, I will come back to it. Just give me a few minutes, I'll come back to it. What does he mean by this? Okay. So I would say to you, reverse the process. Ask everything, right? Ask everything. Ask questions. Be that person who asks question. I'm going to say this to you today. If you go and ask somebody a question and their response is, you should know better, or you shouldn't ask, yeah, why don't you read about it? So, the litmus test for you to find a mentor, this is the litmus test. You go to them and you ask them any question on anything academic, anything clinical, right? अब जाहिर है आप उससे जाके पूछेंगे, सर आज आपने इस महीने कितने कमाए, तो वो he's going to get pissed off. That's not the right question. So you've got to have the right question from the right person. So you go to the person, and any doctor or physician, and you say to them, you ask them a question. And if their response is, oh, you should know better, and if you think the eyebrows go up, or if you think, they got upset about you asking the question, they're not the right person to talk to. They're not your mentors. The reason I say this is because अमूमन तौर पे you get these reactions from people who don't know better, or who have either some form of an ego problem and do not want to एक होता है ना कि, so for example, if I don't know anything, I would set my ego aside, and my answer is, that's a good question, let's think about it, or I will come back to you with that, because that allows me to think as well. I'm teaching and I'm learning at the same time. Nobody's perfect, right? So you've got to find somebody who says, all right, that's an interesting question, let's look into it. That is the mentor you should be looking for. So this question is the litmus test. You should go and ask people questions. I always say challenge the previously held beliefs. There's a difference between principle and guidelines. So when you make a neck incision, for example, if you make a skin incision, the principle is that you hold the edge of the skin with a tooth forceps. That's principle. You cannot change that principle. Why? Because if you hold it with a non-tooth forceps, it crushes the edges of the skin. It takes away from the dermal plexus. There's high risk of injury. There's high risk of wound adhesions. There's high risk of wound infection. It's evidence. The principle is you hold the skin edge with the tooth forceps. It's principle. It's laid down. It's written in stone. Everything else is guidelines. What I mean by that is हर 4 साल के बाद guidelines change हो रही होती हैं. If you look at, ये कौन सा course है अपना, you have this BLS course. Which is this course? Basic life sport. Which one is it? एक तो ATLS ALS है ना, एक BLS है शायद, basic life sport. Every 3 years आप इनको मोड़ के देखें, कभी वो ABC कह रहे होते हैं, वो फिर कहते हैं नहीं वो BCA होना चाहिए, फिर ABC होना. They keep on changing it. Why? Because it's guidelines. It's not principle. You see the difference between the two? So principles never change, guidelines do. So find the right person who is A, able to answer your questions, B, who's able to help you challenge the previously held thoughts. And I'll give you an example. I'll give you my example. Now, I was a R4 at AKU. I was a 4th-year trainee. And there's a simple question that came to my mind. So when you perform thyroid surgery or a parotid surgery or a neck dissection, general surgeons put in drains in the abdomen. So let's not talk about the general surgeons, right? Let's talk about ENT. So when you put in a neck drain, when do you take it out, right? So the question is, when do you take it out? So some people say when there is 30 ml in one day, you can take it out because it does not lead to more collection in the neck. The rest of the fluid that forms, the body absorbs it. Some people say 25, some people say 20, some people say 15. Now, I was in R4, and it just occurred to me one fine day, it occurred to me, I had 7 consultants, 8 consultants, either American trained, US trained, UK trained, Pakistan trained, I mean, yeah, I had a whole group of consultants. So internationally trained, right? And both nationally and internationally trained. And it just occurred to me, I mean, I'm having one consultant say to me, yaar, if it's 30 cc or less, just take it out. It's this one consultant who was fussed about 25 cc, and there was another one who's fussed about 20 cc. And it sort of occurred to me, what is the answer? I mean, we're working in the best institute in the world. What is the answer? Or do we not have a consensus on this? As in, like, genuinely, what is the answer? So the first thing I did was I went to all 8 of them. I went to all of them. And I started asking them this question because day in and day out, the ENT department at AKU is doing one thing, and more than one thing, is doing a lot of head and neck procedures. That is what we are known for. Big cancers, we're resecting them. These are big procedures, and we are taking in the complex cases from Pakistan, right? But we didn't have an answer. So I started going to all of them, and I started saying, and you've got to be very polite, you've got to be very gentle, you can't be arrogant, you've got to be, just, you how to frame a question is another art, right? And I would go to all of them and I would say, sir, we take the drain out, but when do we take the drain out? Is it 30? Is it 25? Is it 20? As in, like, are we following a guideline? Is there something? And one after the other, you name the consultants who are working there. They are my mentors, and I love them. They have trained me. I'm the man who I am because of them. But nobody had an answer. Nobody had an answer. I would hear funny answers. I'm not going to tell you the funny answers, but I had one consultant say to me, oh, well, if you put an ultrasound probe on the neck, if it is 30 cc or less, you don't find any collection. Now, I know that this is a funny answer because if there's a 2 cc of collection, a pus abscess, an abscess in the neck, even 2 cc can be picked up. If there's a 0.5 centimeter nodule in the thyroid gland, the ultrasound can pick it up. So I knew that was a funny answer. Now, I did not. Okay. And I was like, all right, thank you. And in my mind, I knew that that's not the right answer. So I went to all 8 of them, 9 of them, whoever, how many ever we had back then, and none of them gave me an answer that was convincing. So what did I do? I did my homework. I went down to the drawing board and I started looking at, I went to PubMed, I went to Google Scholar, and I started looking for neck drain removal after neck dissection or thyroid surgery or head and neck surgery. One after the other, I could not find any evidence, right? And then very interestingly, what I did was there's a concept of citation and reverse citation. So reverse citation is you pick up the paper that has cited the paper that's talking about it, and you open up that paper. So I kept on going back and back and back and back and back, and you would be surprised in what I found. So Stelmaran is the Bible of head and neck surgery. In the 1956 में इसका एक volume publish हुआ था. In that, I downloaded that volume. I went to that chapter which was cited, and I read through that chapter, and there was one line in the Stelmaran 1956 chapter that says neck drain should be removed when there is approximately 25 ml per hour or less. And in brackets, it very explicitly said there is no evidence for it. Full stop. And I was sitting over there. I still remember this day because I still get goosebumps. I was sitting over there. I was sitting in the attic at AKU. And I was like, we are practicing all over the world. It's not AKU. It's not Pakistan. It's not Afghan. It's not Karachi. All over the world, the neck drain is removed on something which does not have any evidence. It's all arbitrary. So somebody now this is my hypothesis, which my discussion ki baat kar raha tha. My understanding of this whole thing is somebody somewhere in history would have said, if there is 1 ml per hour or less, that equates to 24 ml per hour, right? We can take the drain out. Okay. Now, अब किसी ने चलते चलते कहा होगा सर देखें 24 तो नापना बड़ा मुश्किल है. So let's do 25. It's like, yeah, it makes sense, right? Because 25 is marked on the drain, 24 isn't. And then I'm pretty certain somebody must have said, hey, let's round it off to 30. And then somebody must have said, oh, well, let's err on the safer side. Let's do 20. So there is no evidence. Actually, there is no evidence. And more recently, in the past 10 years or so, there is very strong evidence that's come out that says, even if you don't put in neck drain for thyroid surgery, it does not affect the outcomes. There is no higher risk of infection. There is no risk of higher risk of serious fluid formation called as seroma. And so all I'm saying is ask the questions. If you don't ask, right, you wouldn't know. So you've got to reverse this whole process, this whole idea of don't ask, just do. ठीक है ना? अब वो जो मूवी के अंदर ये टॉप गन मैवरिक का जो मैंने आप लोगों को वो जो आई शोड यू द वीडियो, उसके अंदर वो जो बात कर रहे हैं ना, डोंट थिंक जस्ट डू, दैट इज अ डिफरेंट डोंट थिंक जस्ट डू. दैट्स नॉट व्हेन यू आर अ 5-year old. When you are in a high risk stakes sort of a situation, you then stop thinking and you do it, which means you have developed, you have put in 10,000 hours and you have developed your reflexes for you to do it. Then your reflexes talk. I'll give you an example. There was a case, I can't say because of confidentiality issues where, there was a patient who came in with an upper airway obstruction and required an emergency tracheostomy, which is a hole in the trachea. And I know I was with my consultant, and the patient stopped breathing. He stopped breathing, right? And we had to make a hole in the trachea, going through the skin, make a hole. And at that time, when it comes down to seconds and minutes, because we know 5 minutes and brain dead, and we've all heard that. When it comes down to seconds and minutes, then you are not thinking. You are basing your decisions on reflexes that you have developed after hours and hours and hours and hours of practice. So when Maverick said, "Don't think, just do," it wasn't the "don't think" के सोचना बंद कर दें and बस लगी हुई एक भेड़ पूरी कौम चल रही है, वो वाला नहीं है. It's the other "don't think, just do," right? So you've got to differentiate between the two. And I've given you my example of Stelmaran 1956, the whole thing, and it's how interesting this is. And one of my colleagues, Abdul Basit, who's a chief resident in ENT, I handed him over the research question. He's done his dissertation for his CPSP for this, on the whole topic, on this whole topic. I've done a few I've done a systematic review of systematic reviews on exactly the same. I've done regression analysis for drain output and parotid surgery. So it's something that, tickled me and tickles me to this day. It's like, we don't have an answer, guys. Come on, what are we doing? World over, even now over here in the UK, I mean, guys, we don't have evidence for this. So when I tell this to people, it does make them scratch their head, is be like, what is he talking about? And I'm like, yeah, go. I mean, go see. If you think, challenge me, come back, tell me if I'm wrong. So, and I'd be happy to be corrected. I want to learn, but there is no evidence, guys. So just saying, but there is recent evidence that's coming up. And that's a different story. Now, one way to do it, like I did it, is observe the difference in practice. What, you've got 10 neurosurgeons in AKU, for example, you observe their practice. So the first thing you've done is reading. You got to read, you got to understand, you got to know. But you can only question something politely if you observe in the difference in practice. What I observed was, one of my consultants was saying, take it out if it's 30 or less. The other said 25, the other said 20. So there was a difference in practice. If there's difference in practice, this could either be based on different guidelines, but that is a good thing that you could perform research on. Which one is better, right? So observe the difference in practice, ask questions, and read about it. When you read about it, you understand. And when you ask questions, hota ye ki you understand the rationale. They will tell you why they're doing it, because you understand the rationale about why they're doing what they're doing. So ask questions, but ask politely. Again, it's important to understand how to frame the question. You don't want to go out offending people. And then read about it. Read about it. It's no longer the time when you don't have access to publications. They're back doors, and I'm not going to name them, but they're back doors when you've got access. In AKU, you've got a great librarian. You can ask them for papers, and they really help you out. And identify gaps in literature. You see, I gave you an example of glioblastoma. That's just it's not my specialty, but if you are able to identify that gap in literature, where nobody's talking about it, then that becomes a research question for you. The very last bit of my talk is quality publications, and I am going to take these questions first, and then I will So, sorry. So I've taken the Okay, so and then let's talk about quality publications. So if you want access to Dr. Enam or Dr. Saad, please do contact Dr. Mahnoor directly, who has started this. So my bad, I called you Dr. Mariam twice, which is wrong, and I apologize for that. So quality publications, how can you have high impact factor publications? So again, for me, the most important thing is research question. I say this to you because I've received the short end of the stick. I've had a systematic review that was a poorly put research question, and it took me 5 years to publish that systematic review. Okay, I've had a good research question with limited evidence, 3 randomized controlled trial. We got it published in the first go. Research, it's very important to have a right research question. If you're answering the right question at the right time, because things do change, medicine does change. If you're asking the right question at the right time, you get an easy publication in a high impact factor journal. If you're carrying out a study of yourself, increase the sample size. The larger the study, the larger the power of the study. It increases the evidence. It increases the power of the study, and therefore you have a higher impact factor publication, a higher level of evidence. If you're performing a randomized controlled trial or systematic reviews, this for the past few years has been my go-to. Why? Because you don't have to collect data of your own. The data is already published, but you've got to have the right research question. Even with a systematic review, I struggled to publish it because it was not a well-put research question. And then, make teams. It makes life easy if you are working in teams, right? And it's got to be a small team, 3 to 4 at max. You can't have bigger teams, 6 to 7 people, and then nobody's doing anything, right? And there's a lot of, who's going to do what sort of a situation. So makes teams of 3 people, that's ideal in my mind. And then you've got a mentor and yourself as well. And then aim high, land high. I always say this: if you want to be the best, you have got to think of being the best. If you want to be mediocre, then so you've got to aim high always. So if you're aiming for any jam or Lancet, then you're aiming high, and therefore you would automatically work in the direction of having a high impact factor publication. I often give an example of the pediatric department at AKU, which almost very not they keep on publishing in high impact factor journals. Pediatric department at AKU has published in NEJM, Lancet, and you think to yourself, I mean, this is high impact work. And if any one of you knows Conor McGregor, he is the he used to be in UFC. So I would want you to hear what he has to say, because I sort of like what he said over here. So I'll leave this to you guys.
If you can see it here and you have the courage enough to speak it, it will happen. So I see these shots, I see these sequences, and I don't shy away from them. A lot of times people believe in certain things, but they keep to themselves. They don't put it out there. You truly believe in it. If you become vocal with it, you are creating that law of attraction, and it will become reality.
So for me, this is important because, we in our culture, culturally as well, and we hear about these things a lot, is when you really want something, even the nature aligns for you to have it. You just got to have that drive. You just got to have that, I won't say motivation, but you've got to have that drive. Why? Because at times actions lead to motivation. It necessarily does not have to be motivation that leads to action. It is the opposite way around as well. When you start writing paper, you feel miserable. Trust me. I mean, it takes a life out of you in publishing one paper. But once you do it and it gets published, it leads to more motivation. So action at times leads to motivation, but you've got to have that drive. You've got to have that vision, is all I'm going to say. And then the frequently asked questions that I get is, do audits matter and should I do it? I would say you should, especially if you're planning on moving to the US or the UK, Australia. Audits do really matter, especially in the UK. I can tell you the UK context. Audits over here do matter a lot, because audits lead to change in practice, and they really like change in practice, because they just don't want to put their head down, and they don't want to just keep on going. They like change in practice. They want to get changed. So And the other question I get is, how will research benefit me? I'm a surgeon, I'm a clinician. Well, again, for this, I will go back to the same slide. We talked about moral obligation, but let's just take it out. Let's take the moral and ethics and the goodwill out of all of this. Let's talk about the personal gains, right? In my mind, as a surgeon, if you are highly published, it gives you acknowledgement. Your peers acknowledge you, they respect you for it. It leads to collaborations. I am currently working with students at AKU. I'm working with students in Peshawar. I'm working with colleagues in Italy. I'm working with guys in Saudi Arabia. I'm working with a guy who's in Cambridge. I'm working with a student in Vancouver. All of these collaborations, and you get to know people, and it leads to networking. I'm working with one of my colleagues in Islamabad Fauji Foundation. He's a student there who is working with students in India and the US, all of us sitting miles away, continents away, are working on a systematic review together. And then, if you are in an academic institute like AKU or any university teaching hospital, it definitely helps you with promotions as well. So in my mind, there are a lot of reasons why you should be a public. And again, if you think about it, you've got two surgeons. One of them is a published surgeon, and the other one isn't. Sure, they could be, treating, the board can take tonsils out, but who would you want to hang out with is my question. I'll leave that to you. So. And then, this is again, travel the world. So when I was in AKU, the research allowed me to travel the world. And what do I mean by that? So because of my publications, so what happens is when you start publishing early, it goes in your portfolio, it goes in your resume and your CV, right? A lot of the conferences in the world, they offer travel grants. The travel grant, the person who is going to give you a travel grant is someone who does not know who Haissan is. I mean, who cares who Haissan is in AKU, in Karachi? Who cares, right? But what they do care is your portfolio. So when thousands of applications go in and somebody has got publications as opposed to does not have publication, all of them are trainees. It doesn't matter how many cancers you have treated. What matters is your publications. So my first travel grant was when I was a year 4 trainee. This is 2018. And this was a 1,000 pound scholarship, travel scholarship, to attend the British Academy of Otolaryngology in Manchester. Then I got a $3,000 scholarship. Basically, so the way this works is they don't give you the money per se, but when I say $3,000, what they do is they would pay for everything. So if you amount that money, at times they declare what the money is. They'll give you that money as well. Some of them. So the way they did not give me the money, but my traveling, my stay in a 4-star hotel, my sinus dissection course was all paid for. And I was also the first sinus scholar from Pakistan. So it helps build. And this guy going back at the back is Professor Islam Harzala. He's a well-known figure in the academic rhinology world. And then I got another $1,500 scholarship. They paid for my tickets. I flew to Cape Town just to present a poster. Can you imagine? It's not even an oral presentation. And this was ICE, which is International Conference of Endocrinology. And again, you get recognition. I mean, it says Haissan Iftikhar, Pakistan. It was amazing. In front of 1,000 endocrinologists, they were endocrine team from Pakistan as well. And I'm a surgeon, right? Going into a physician's conference because I'm presenting something on an endocrine gland. It was a proud moment because, you're representing your flag. And then, you get to move around. जब आप जाते हैं तो अब ऐसा तो नहीं है कि you land in a conference, you come out. Yeah, this is the biggest botanical garden in the whole of Africa, in Cape Town. So, you go around, you enjoy your time, and you sort of have fun, and it sort of gives you that break as well. So what does it lead to? It leads to travel grants, scholarship, recognition, connection, and all of that. I would always say aim for the best journal. Think about the highest level of evidence. Aim for the high impact factor journals. In general, the next few slides it's all about selling your product, right? It's how you sell your product, which is your research. The reviewer has a job to do, which means that they will reject some papers. It's their job. Aim for the best journals, and it's sort of a symbiotic relationship, right? I mean, if you don't publish, these journals don't work, right? It's like if you don't buy a product from a store, I mean, that's how it works. It's symbiotic relationship. And publishing is easy. It just requires a lot of persistence. Papers do get rejected, don't get dejected from that. There are over 25,000 journals, index journals that you can publish it. Um, Discuss authorship. This has always worked out for me. Rule of third: if you're working in a group of three, you decide up front who's going to be the first author in which paper, and you work on three papers. Everybody gets to be the first author. And there's a concept of joint first author, just so that you guys know, which means two people can go in as first authors. Okay, so that's another. You write to the journal at the time of submission, and you say both of them worked equally on the project and therefore are going to be joint first authors. Most journals have started accepting that. Make groups, divide the work. That helps. As of 2017, these are the figures from 2017. There were 2.5 million papers, like 22.5 million papers published in 2017. There were over 1 million index journals. That includes all specialties, everything. Outside medicine as well. And who knows what the figures is in 2014. So this was 7 years from now. 2024. Who knows what the figure is now? Do one. You will learn how to do a research once you have undertaken one yourself. So get hold of a mentor, get hold of a coach, and the moment you do your first project, like I did my first case report, it just gave me a hang of everything. I was like, this isn't difficult. It's just a lot of work, but it isn't difficult. You write introduction, material methods, you get pictures, you go to the histology department, you get the slides, you write the discussion, you reference it, and then you submit it. But once you do it, once you've done it, nothing is difficult. It's just about practice, isn't it? So, and in summary, if a research question is significant in my mind, the results do not matter. It could be positive results or negative results. It does not matter. If the question is right, the journal will publish it. Trust me on that. Manuscript body has 4 broad components. We've talked about it: introduction, methodology, results, discussion, and then conclusion and abstract at the end. Get hold of a research mentor and then do one. Once you do it yourself, it just makes it easy. You understand it. What does research lead to? It leads to recognition, and I say travel the world for free. I mean, it really helps, and it helps with the career. So that, in essence, is the end of my talk. And I am happy to take any questions, comments, queries, or suggestions.
Thank you so much. I believe this has been one of the best sessions that we had. Dr. Haissan, we had a very recurrent question coming in, which was how to connect with you.
So I can ask you to share my email address. I was supposed to, let me just do it as we speak. I was supposed to, and I had this in mind, to put in my email address for you guys. So this is my email address. You can take this down, and I'm happy for you to contact me via email. And I'm happy to mentor a few of you guys for projects as well. There was another there was another question by Dr. Zanera saying, asking about how did I go to UK. So there are different pathways to going to the UK. So you can give PLAB, the MRCS. I went through the fellowship pathway, but that was not the CPSP fellowship. There's a very small way, but that route of going to UK, the one I got, is so rare that I would just consider myself lucky I got it. But you have to complete your training first for that. That's called sponsorship. So which means that I did not have to give PLAB or MRCS. All I had to do was to give IELTS or OET. And then if you get a fellowship in certain institutes in the UK which can sponsor the GMC, so they will write to the Royal College, and the Royal College will sponsor you the GMC. So I took that route, even though I have MRCS, but I took the route of sponsorship. So I got the fellowship, and my fellowship director emailed the Royal College, and Royal College sponsored my GMC. And I'm more than happy, guys, if you want to ask me any questions, if there's anything you'd like to ask. I hope there was some takeaway from this talk.